Good evening, friends. Welcome to the DBMCI MDS exam analysis session. I am Dr. Himani Joshi, the original guru for oral and maxillofacial surgery and the academic director for DBMCI MDS. I welcome you all. I know you guys are tired. It was an day exam, an afternoon exam of 2 to 5 p.m. A lot of traffic on the roads, nap times, hunger times. But one thing which is most important is, guys, the exam is over. All right. I am just turning on my YouTube. Whatever you want to talk to, whatever you want to message, my messages are on. You can just text you can chat with me on text. And just the first question from me to all of you is, how was your exam? Yes, I know it was hot. Most of the centers, the ACs were not working. Around me, I had students. Some were very serious, some were very uh, focused on their exam, some were tensed, some were very very casual, saying मुझे तो बस एक private college की कोई भी seat मिल जाए. So I've marked only 82 questions out of 240 because to pass I need only 60 and 60 out of 80 will be right. So this kind of discussion I was hearing around me. And guys, it was not easy. All right. Sitting in one place, an exam of two unequal parts with a voluminous syllabus of 19 subjects. First of all, a hats off to all of you, every single person who has well prepared and who has sat there sincerely trying to take the exam nicely, trying to do their best. So first of all, congratulations to all of you. The big exam is finally over. Let's begin with the analysis. So, a lot of DBMCI faculties every year take this exam, okay? Me, Dr. Aishwarya, and a lot of in-house doctors, subject specialists take the exam to not just know the pattern and all that, to also understand what it goes among the students' minds. All right. As a faculty, I felt part A and part B were not equal. Okay. Part A definitely had longer questions, had clinical scenario based questions, needed more time to solve. So it was slightly lengthier as compared to part B, the dentistry part or the clinical part, which had a lot of straight one liner questions, a lot of bang on questions like syndromes and all. And yes, definitely some clinical scenario based questions also, but slightly less lengthier. Okay, before we begin with my version of the exam, let us see what exam students had to say for the exam. So, immediately after the exam, we had a survey. All right, a lot of students participated in the survey, and this is what they had to say. 10% students said it is easy. All right. 15% students said it was difficult, and 70% students said it was moderate. Okay. Like we always say, see, in any exam, 60% of the paper is doable, which is in the easy moderate category. All right. 40% questions are moderate to tough. The problem with good students is that whenever we come out of the exam, we always remember these questions. We always think that, these questions are the things which, these are questions are the ones which will decide your rank. These questions are the one, maybe you were right, maybe you were wrong. Relax. These are the questions which actually decide whether you get a government seat or not. Okay, it is these 60% easy, doable questions, which I'm sure most of you who have prepared nicely, you've done correctly. Direct questions like Perry Robbins syndrome, direct questions like, Gary's osteomyelitis. So many direct questions, which usually the good student does not remember after exam. What he remembers is the difficult questions, which took a lot of time to answer, or which he or she was doubtful among many options, among two options. So don't think that it was only a moderate or tough questions that were there. Definitely, you have solved questions that were easy, which is why most of you found the paper moderate. What I believe was part A was moderate to tough, and part B was easy to moderate. I will not call it completely easy, because some subjects are very, very easy, like oral surgery, lot of repeats. Mostly it was straightforward questions. PhD questions were straightforward. Pedo questions were straightforward. But dental materials, very, very tough questions. Okay. Cons endo, not so easy, moderate questions. So it was a mixed bag. Why I'm calling it easy is because there were direct repeats. Okay. Even in questions that were looking like new, the options were very easy. The options could be ruled out. Okay. You would never expect the examiner to ask you antrolithiasis, rhinolithiasis, and cyalolithiasis in a straightforward question. So definitely there were very easy questions in part B, but yes, certain questions were moderate, uh, or a little difficult. So overall, the paper was moderate. Now coming to the clinical scenario based questions. Okay. At DBMCI MDS, we are really proud that every faculty doesn't just teach you the theoretical concept, they apply the concept in a clinical scenario so that the application of that theory becomes easy. Okay. 60% students felt that, 60% questions, the students felt that 60% questions had clinical scenario. This is very, very true. Questions like physiology. Okay, we all know that since the last few years, a lot of clinical scenario based questions are being asked in basic subjects also. And this was true this time also. Instead of asking directly facial nerve palsy, the examiner made it a long question. Like, a young boy had trauma to face. He was hit by a broken glass bottle, and now he cannot raise his eyebrow. He cannot close his eyes, and he cannot smile completely on one side. But his vitals are stable. So, which structure is damaged? Whether it is the submandibular gland, whether it is the masseter, whether it is the parotid. So, straightforward questions of parotid nerve injury, parotid gland injury causing facial nerve injury, asked in a very twisted fashion. Okay, same for physiology like questions, aphasia related questions, or even pharma questions of a child being allergic to penicillin. So what would you give in a case of acute abscess? So lot of clinical scenario based questions, which shows that the trend is going towards a next. Very soon there will be a next, which is more of a practical application of the theoretical knowledge, which is once again proved in this exam. Just mugging up the answers, you will not be able to answer the questions. Clinical application of the knowledge you have seen in 60% of the questions. So this I agree with most of the students that around 60% questions had clinical application of the theoretical fact. Rest of the 40% straightforward. Okay, which nerve passes between the loops of auriculotemporal nerve? Straightforward question. Which muscle will be damaged by injury to the origin of the inferior alveolar nerve? Straightforward question. Okay, micrognathia, glossoptosis, and cleft palate, which syndrome? Straightforward question. Mulkerson Rosenthal syndrome, which the features and which syndrome? Easy, straightforward. Lot of straightforward PhD questions, straightforward. Bias related questions, straightforward. But yes, a lot of clinical scenario based questions, which you will see in the recall starting in next 15-20 minutes. Did previous year recall questions help? Now, here is a little controversy. A lot of students sitting across me said, koi fayda nahi hai PYQ padhne ka, and what is the use? I could not answer, and I'd mugged up the PYQs. But surprisingly, in the survey, 84% students felt that definitely the previous year recall helped. Okay. Now, when I sit for the exam, as an oral surgeon, all right, I am purely an oral surgeon, although I had an All India rank 6 back in 2012. But obviously, I do not remember the basic subjects, dental materials and biochemistry and orthodontics, pedo, perio, all these things. But even then, it felt like these questions are seen, these questions are heard, these questions have been repeated previously. All right. So a lot of PYQs maybe not asked directly, but like this. Okay, little twisting of questions here and there. Instead of asking a patient on heparin, on aspirin therapy, 75 mg aspirin, he was going for extraction. What is the protocol? You don't need to stop aspirin. So the same patient, if he wants to go for a root canal, what will be the protocol? So basically, it is the previous year topic. Like we always say, it is always a previous year topic and not necessarily the previous year question which helps, which is why we stress on understanding the concepts and reading the explanations also, along with the question. So lot of, yes, definitely lot of previous year recall questions were there. Was the paper lengthy? 63% students felt that it was lengthy. Yes, even I would agree that part A was lengthy. One of my star students left three questions because he was short of time. Yes, it was definitely lengthy because of the length of the questions. Okay, as a faculty, sometimes the questions you can mark very easily, but as a student you need to be double sure before marking an answer green. So for that double surety, yes, it was lengthy, especially part A. It was lengthy. Medicine questions were lengthy. Surgery questions were straightforward, but yes, they had long scenarios, so they were lengthy. You needed to think about them. uh, Physiology questions were lengthy, so yes, it was a little lengthy paper. Questions asked from COVID? No, there was no question asked from COVID. Recent advances? Yes, few questions were asked on recent advances, especially in dental materials. This is one surprising thing. In dental materials and in prosthodontics, so implants, usually we are seeing this trend that implant based questions are being asked recently. Other than these subjects, some ortho questions were also recent advances, but most of them, they were not very latest kind of things, which are usually seen in INI. We see a lot of recent advances being asked in INI, which is not the trend in NEET. Okay, so 68% students felt that recent advances were asked, new topics or latest advancements. Like if I talk about oral surgery, uh, maybe the TMJ question where there was no clicking, popping, maybe that you felt was TMD, which is a recent advance, but it has been asked. The topic has been asked previously. So yes, a few latest advancement questions being asked, but broadly, the paper was not on very, very trending topics. High yield topics were asked in maximum subjects. Now, what are high yield topics? Before the exam, we tell you that, these are the topics which are most important. Okay. Like when we talk about general surgery, if I give a simple example of general surgery, okay, and anatomy, these are the two subjects I will talk about here. So, anatomy, we all know. When we read it in the first year, we give maximum importance to head and neck. But we also study upper limb, lower limb, thorax, abdomen, embryology, histology, okay, osteology. We read everything. We read all of this as a first year student in anatomy. Whenever you prepare for NEET or INI, we always tell you what is most important is head and neck. Even if you're studying embryology, embryology of head and neck. If you're studying histology, histology of head and neck. Salivary gland, SNI. Osteology, head and neck. And that is the high yield topic in anatomy. If you start studying anatomy with the lungs or with the kidneys or with the lower limb, definitely it will be a waste of time. Which is why before the exam, we give you a high yield list of high yield topics, muscles of mastication. Now, you will all agree that, at least 10 questions were there from muscles of mastication. Okay, whether it is oral surgery related hemimandibulectomy or power stroke related questions of mastication or, nerve supply of muscles and so many questions on muscles of mastication. And this is the basic high yield in anatomy. So definitely it was from the high yield topics. If I talk about general surgery, what we read? Basically, we read thyroid, we read neck swellings, we read oral cancers, we read dermoid and epidermoid, all the cystic swellings of the neck, swellings of the scalp. Okay, basic as thus general surgery, right? So most of the questions in surgery, salivary glands, we read a lot of salivary glands. Every salivary gland was asked, from cyalolith to ranula to Ludwig's angina to parotid injury, superficial parotidectomy for pleomorphic adenoma. So basic high yield topics, definitely questions were from the high yield topics. See, when I say this, all those who felt that the paper was difficult, don't think that I'm saying that every question was easy. No, I'm not saying that. Okay. 60%, 60 to 70% questions were doable. This is what I'm saying. And definitely there were 30 to 40% questions which were not doable, which were difficult, which we had not read. Okay. But always remember, beta, these are outliers. These questions, maybe if you are in the top 200 ranks, they will help you decide whether you are in the top 20 or in the last 200. But they will never decide whether you are selected or not selected. Right? It is the 70%, 60-70% doable questions which always decide whether you are on this side of the river or that side of the river. So, yes, definitely high yield topics, exodontia, local anesthesia, cleft, pathology, infections, even from oral surgery, no questions from orthognathic surgery, no questions from distraction. That means topics from BDS, simple topics, high yield topics were asked in maximum subjects. All right. So I agree with the students that most of the topics were from the high yield topics. Okay, this is a little happy question that majority of the questions were from what? So most of the students said either it was from the live class notes or it was from the hard copy notes and e-Gurukul question bank. I'm very happy that when we do a recall tomorrow, you will see how every question is discussed by the faculty, either in the live class, so there will be screenshots, or from the notes. So you will have screenshots of the notes showing that, questions were discussed very nicely in every subject, majority of the questions. All right. So very few bummers. Majority of the questions could be read from the DBMCI notes. Okay, how many image-based questions were there in the paper? Very few. Surprisingly, very few. Till last year, they were asking image-based questions in general surgery, physiology, anatomy. Surprisingly, no image-based question in anatomy. Only one or two ameloblastoma, life cycle of ameloblast, and the CEJ, cemento enamel junction का जो ground section था, and the mucogingival junction related question, and very very few image based question. One ego wala question in PhD. All right, and multiple myeloma. There could not have been an easier question where punched out radiolucencies are also seen. M spike is also seen. Everything is given. So in medicine, they've asked medicine or oral medicine. Multiple myeloma is asked. Gary's osteomyelitis. And what all image based questions? I will just see. Yeah. So X-ray source, distance between the source and the mid-sagittal plane of the patient. Same thing is written on the question. Same thing is there in the image. And a patient with a mandible and soap bubble appearance of the whole ramus, mild buccocortical expansion, easy image-based question. CEJ, I've already discussed. Orthodontics, the Ackerman profit classification 345 were asked. So, pedo question, very, very easy. Unerupted 6, age of the patient is asked. So, basically, image based questions were few, around 10 to 15 maximum, 10 to 12 image based questions, and they were easy. All right, they were not something which is out of the box. कोई membrane है जो देखी ही नहीं है, ऐसा बिल्कुल भी नहीं था. Most of them were doable. All right. So, this was the analysis based on your feedback, based on most of the students who we asked, and based on the Google form that we circulated among most of you, and your feedbacks. Now, let us quickly see subject by subject distribution, how each subject was. All right, let's start with part A. And let me again tell you guys, most of you, okay, belong to two categories: students who have studied and students who have not studied properly. They have just tried to take this exam. All right. These kind of students will have, kind of no feelings. These students, I'm sure most of you have no feelings because you've tried. Okay. You are cool, you are casual. Students who have studied, you will have mixed feelings. You will be happy about some questions. You will be very happy about some questions that, oh, this sir had told in the class or this ma'am had told in the class and I could remember it. Okay. Like I remember this question on lignocaine toxicity. Okay. It is a part B question. Question on lignocaine toxicity and CNS depression. The only effect is CNS depression. Now, I know at least what 70, 80, 100 times I have answered this doubt in the Telegram groups. Okay, I've pinned this answer at least what 50, 60, 70 times at least in the whole year. So I'm sure most of the students who've asked this doubt and you've seen this question in the exam, you're very happy. But again, you're not sure because, even if it is an easy paper, for everybody it is easy. If it is a difficult paper, for everybody is difficult. So competition always remains the same. So don't think that you are alone who is having mixed feelings. Everybody, every student, even the one who's going to get rank 1, even that girl or boy must be having mixed feelings at this point. You are never sure. All right. So just remember you are in the same boat. Relax today, sleep well, and let's just analyze the part A. Anatomy, I will call it moderate. Okay. There were hardly any PYQs, no PYQs, but applied questions were easy. All right, easy to moderate. So anatomy was moderate. A lot of clinical questions were there in anatomy, clinical based questions. Uh, like the superior bulb of the internal jugular vein is in relation to which part of the tympanic cavity. Now, honestly speaking, this question is repeated long back in the 2011s and 12s in AIPG. All right, and this they have repeated. Then the broken glass bottle question, the facial nerve injury, pre-traumatic supply of the first pharyngeal arch. Trismus is caused by and now the options are all the masticatory muscles, and there you have to choose. Uh, Neural tube defect question. Okay, the child is operated for neural tube defects. The dura and arachnoid are intact in the spinal cord. Only the brain arches are defective. Now, these are difficult questions. Okay, the neural tube defect question was really difficult. Okay. So whether it is meningocele or meningomyelocele, it is difficult unless you've read the answer, you've read about the disease. So anatomy was moderate to difficult, I will call it. Similarly for physio also, some questions were direct repeats. Okay, like the aphasia question, Wernicke's and Broca's aphasia question. Some questions were clinical and tricky. So I will again call physiology moderate to difficult. Biochemistry, thankfully, very little biochemistry was asked. One question was there in part B. Demyelinating disease of the spinal cord is caused by deficiency of which enzyme, which vitamin? That is B12 or it is a pantothenic acid or B6. So biochemistry was very less. So it was a harsh for most of them. Pathomicro, very clinical, very, very clinical. Okay. Most of the questions were clinical scenarios. Thankfully, no image based questions. Some were easy, like, the starry sky appearance. And I know some questions were easy, some questions were direct, but very, very clinical questions in Python micros. I would put it in moderate to difficult category. Medicine, again, moderate to difficult. Complete heart block on ECG. We have taught it. All right. The DBMCI students must be happy in answering this. We have taught, but on a general, on an average, it's not really easy to answer questions on ECG. So, not a straightforward question. Pharma, pharma was also moderate. Some questions were easy. Okay, like heparin antidote, paracetamol poisoning antidote. Okay, and patient allergic to penicillin, child patient antibiotic of choice. So some were straightforward questions. Some questions like this question on anaerobic, which is the most used antibiotic for anaerobic infections, clindamycin, metronidazole. Some questions were so straightforward. So those were easy questions. I will call it really easy. Some questions, although were moderate, all right. Pharma questions like 50S ribosome wala, but we know that most of us know it. And adulterant, this adulterant wala question. Okay, this was really difficult. Question on the adulterant used in pharmaceutical products, which is causing a severe AKI, which is causing severe acute kidney injury in globally among patients. Okay, so it was methylamine or ethylene glycol. These were difficult questions. So pharma, I will call it moderate to difficult category. Surgery, now I will be biased for surgery because as a surgeon, most of the question I felt were direct. Okay. And two topics were favorite in surgery: ATLS and salivary glands. And we teach these topics in depth. ATLS, right from cervical spine injury to penetrating chest trauma, to Ludwig's angina needing tracheostomy, and every salivary gland questions being asked from ranula, treatment of ranula, and there was a parotidectomy question. And there was Ludwig's angina question. Ludwig's was not mentioned, but a proper clinical scenario was given where there was a submandibular swelling, raising the floor of the mouth, trismus, CT is showing cellulitis, a flex of abscess. So what will you do? Obviously, you will do a tracheostomy. So these questions based on salivary glands, questions space infection, question based on wound, 12-hour old patient, old trauma, dirty, grossly contaminated wound. What will you do? Whether you will put a drain, you will do primary closure, you'll put a skin graft, or you will just debride and leave it. So questions on salivary glands and ATLS was the highlight. All right, and a lot of clinical questions, which I felt as a teacher or as a surgeon, I felt they were direct. Okay, midline swelling of the neck, they cannot be more direct question. Swelling of neck, midline, which is moving with protruding the tongue, moving with deglutition, what investigation? And scalp swelling, which is filled of keratin. So these are straightforward questions, direct questions. These were not indirect questions. If you have read surgery, if you have read the facts in surgery, basic S das, thyroid surgery, neck dissection, these were tricky questions that, uh, certain clinical scenario based that a unilateral neck dissection is done and patient presents with swelling and pain. So what is there? Is there hemorrhage? Is there an infection post-operatively? These were difficult questions, but most of the questions surgery, they were direct questions. All right, guys, again, I'm saying it is absolutely okay if some questions are right and some questions are wrong. All right, do not panic, do not get restless, do not think ki mera kya hoga. Just remember, again and again, I'm repeating, all of you are in the same boat. All right. You have to keep yourself gathered because there is still an INI coming up. Those who have filled the INI form, keep yourselves gathered. Do not be happy. Do not be sad. Just be stable. All right. So this is part A mostly. Other than that, there was DADH. DADH was easy. DADH was nothing difficult. DADH was straightforward. No problems with DADH. Coming to part B, OMR. Okay, just tell me now. I want to ask you guys, how many of you felt OMR was easy? Straightforward questions in OMR, all the X-rays, everything. Uh, how many of you think it was easy? Yes. So Kaushik is saying. So I'll read your YouTube comments in some time. Uh, but just let me know how many of you felt OMR was easy. Okay, let me put it easy to moderate. OMR was easiest. Okay, I'm very happy that most of you are saying that OMR was easy and it was a lot of OMR questions. Okay, submental vertex view for zygomatic arch fractures, lateral skull view for nasal fractures, distance of the cephalogram from the X-ray source, dentigerous cyst, and most of the questions were moderate. I mean, easy to moderate category. Oral surgery, Definitely, it was easy. Okay, except for two questions. Okay, only two questions were tricky. I will discuss them tomorrow. One of oroantral fistula and one of the clicking popping wala TMJ wala question. But that was also a repeat question. So I know most of you have marked it correctly. Just massage and leave the muscle. But it was fine. Oral surgery was not something you've not heard. Questions were on. What was there in oral surgery? मैं oral surgery बोल रही हूँ. Hmm. Cyalolith question and antral carcinoma, antral malignancy question and oral surgery का osteoradionecrosis question. Okay, patient on radiation therapy needs extraction. So easy question. Um, Timing of surgery of cleft palate. Easiest question. Mm, Champy's principle, superior border plating, functionally stable. So all questions were everything that you have studied, you have done. We've discussed concepts, so it was easy. Okay. Prosto questions. I still have to get a feedback from the Prosto faculty because I've blindly left Prosto questions. But there were implant questions. There were questions on an implant which were easy. Implant questions, what is the distance between two implants? You have to put multiple implants, straightforward questions. Okay, prosto questions were many. A lot of prosto questions, and there were many. All right. Dental materials. I think this was the most difficult. This was the most difficult subject. Dental materials was the most difficult subject. A lot of new questions. And as we all know, dental materials is all facts, facts, facts. So, a lot of new questions in dental materials. So, I felt dental materials was the most difficult subject in the part B category. Other than that, ortho, pedo, perio, they were all easy to moderate. PhD also, I will put it in the easy to moderate category because straightforward question. Okay, patients entering the hospital, what kind of bias? Some questions were difficult, like that doctor wala question, shoeless, chappal-less doctor, something like that. So some questions were difficult, but most of the PhD questions were straightforward, no bummers. Orthopedo, perio questions, mucogingival junction, and we do also the caries classification questions. Ortho also some image based questions and what appliance will you use for skeletal expansion after the sutures are fused. So I think they were all straightforward questions in orthopedo perio. All right, cons and do. Dr. Aishwarya is just going to take your session. According to Dr. Aishwarya, it was moderate. It was not very easy. It was moderate. The middle, mediobuccal middle canal and radix endomolaris, ectomolaris was not easy as a student. Yes, as a faculty, as a clinician, it is easy. But for a student, it is not easy. So he's put it in the moderate category. What have we left? Cons and do. Dental materials, prosto, ortho, pedo, perio. That's it, I think. So broadly, I think part A, difficult. Part B, moderate. All right. Always remember, guys, paper, whether it is easy, whether it is tough, competition always remains the same. So, all those who were calm, composed, I'm sure you've all done well. So, do not doubt yourself. All right. Just remember, the exam is over. All right. If you guys want to ask me anything very quickly, just don't ask me the answer to the questions. We have a special recall session for that. This is the schedule for the recall session. I'm sure most of you have this schedule with you. Immediately now, after this session, we will have Dr. Aishwarya with us. He will be taking dental materials and consendo. Followed by that, Dr. Ruchi will be taking Prosto, and after that, Dr. Garima will take PhD. Tomorrow, 12 o'clock onwards, we will have all the other subjects recall, exact questions, and correct answers. Okay? Okay. All right. So, a lot of you are in a joke, fun mood. I'm very happy that you've now taken the exam lightly. And Yeah, so post-convulsion depression questions repeated multiple times. Yesterday night, I had seen PYQ solution. All right. So thank you, guys. I think this is it for the analysis. Anything you guys want to ask or you want to add here, uh, you can let me know. But I'm sure most of you have done well. All right. Those who have studied, those who are tensed, just take a deep breath and take a break, right? It's not necessary to stay awake all night. Just relax and sleep well tonight, guys. A lot of hard work you guys have put in. And today, for most of you, it has come to an end. All right. Just just wait for the result. Those who are not preparing for INI, you can take a small vacation, can go out, travel. Those who are preparing for I will recommend just take a 1 day break, maybe today and tomorrow, and come back for INI because we have just 1 month left. All right. We'll finish the session here. All the best for result, guys. That's it. Good night.
Live. Hello, friends. Good evening. This is Dr. Aishwarya Kaushik. Now, today has been a very strenuous day for all of us. This is the day when this is actually an important day for us, for all of us. NEET MDS 2025. We are here to, do the analysis of the questions that have been asked. As you all know, I'm Dr. Aishwarya Kaushik, your faculty for DM and Endo, right, guys? As far as the paper was concerned, a lot of questions. The second part of the paper, a lot of questions from DM and Endo. Endo, yes, if you knew the concept, the logic, you would still be able to solve them. DM, I thought a few questions were brand new. And again, the examiner, in order to differentiate between people who've been studying extremely hard versus the ones who are studying okay, they do put these questions in which, certain questions are brand new, some questions are taken from unverified sources, as I've seen the paper. And some questions are taken directly from the textbook, but they're brand new. So we'll discuss them. The first question, again, a new question, but a new question in the sense that it is not a PYQ, but it is taken straight from Philips. Very confusing options. If you would recall, a patient underwent a ceramic restoration. I've kind of simplified this. So I'm going right to the brass tacks, the most important thing. Patient underwent a ceramic restoration. Now the clinician wants to finish and polish it. Now, what is the order, guys? So, if you know, in general, for any finishing and polishing, what do? You do bulk reduction, you do contouring, you do finishing and polishing, right? Now, with a ceramic crown or a ceramic inlay or an onlay or a veneer, so what you basically do is you do your routine contouring, finishing, polishing with with the protocol that you follow, with whatever aluminum oxide or green stones or whatever stones that is there to follow. The examiner is not asking you that. He's saying that when is it that you apply the glaze, the overglaze or the natural glaze in this entire protocol? And very clearly from your Phillips, first you do your contouring, finishing and polishing, and then finally you place, you fire your restoration at a slightly lower temperature and you place your layer of overglaze or natural glaze after that. If you see the options, I've been very precise with the options, right? So the first option was apply overglaze or natural glaze before contouring and finishing. Absolutely not. Apply overglaze or natural glaze before contouring, finishing, and polishing. Just to confuse you, doesn't make any sense. Apply overglaze or natural glaze after contouring, finishing, and polishing. So that's the answer, guys. Straight from your textbook. And then the fourth option was even more confusing. Apply an overglaze on the natural glaze after contouring. Doesn't make sense, right? Then there was this image-based question in which You had both the X-ray as well as the clinical picture. That was pretty logical. We do traumatology, as you all know, we do traumatology in great detail, right? In our discussions, in our lectures. So the question goes like a 15-year-old patient who suffered traumatic dental injury 5 years back, right? Now has come to the clinic. And what is the complaint? The upper right central incisor. So that's your 1 1. I'll simplify this. So 1 1 is TOP positive, right? Then um, it's on the X-ray, there is a proper wide open apex, right, with very thin dentinal walls. If you saw the X-ray in the exam, you would actually say that this is a blunderbuss canal, right? No strength to the root, right? Then there is a big periradicular lesion, right? Radiolucency, signifying a chronic inflammation, right? Then what next? There is a mesiodense in between your 1 1 and 2 1, right? Then pulpal sensibility or sensitivity tests are giving you a negative response for 1 1, 2 1, and 1 2. Right now, the question is, so all this information is there. The X-ray is there, the clinical picture is there, which is not, which is not the correct treatment approach, right? So, what are all the possibilities except for one situation, one option which is absolutely wrong. So, let's see all the options. The first option is apexogenesis of 1 1, right? Before discussing the answer, I'm going to just see the all the options first. Regenerative approach for 1 1. Why not? You have an open apex case. You have the root. If you remember the X-ray, the root is practically, just hardly half of it is formed, blunderbuss canals, wide open apex, 3 mm in diameter. That information was also there. So big open apex. The thickness of the dentine of the root is very thin. So why not regenerative? This is, as I've so many times discussed with you guys, this is Schweck's 1, 2, or 3, right? Not reaching 4. So actually, regenerative endodontics is a better option than going for apexification, right? But obviously, apexification also can be done, but better is regenerative. However, this question does not ask you what should be done, what should not be done, right? So regenerative, of course, you can do. Apexification you can do, but you would prefer in such cases to kind of bring back the thickness of the dentine and bring back the root length to some extent, right? So apexification can be done. Surgical approach. Why is this right? You've identified a mesiodense, right? So you would want to remove it. You identified a big, periapical lesion. You feel that there are three teeth which are non-vital. So many people can go for a surgical approach. Although for the management of a periapical lesion, you always try the orthograde approach, non-surgical approach first, and then the surgical approach. But again, because there is a mesiodense, a surgical approach won't be wrong. What is wrong here is apexogenesis, guys. I mean, this is a non-vital tooth. This is a periapical lesion. This is a history of trauma 5 years back. Apexogenesis can only be done in a vital tooth, in a root which is having some healthy radicular pulp. It's not there. So apexogenesis cannot be the right terminology. It's absolutely wrong. So that's the answer. Apexogenesis cannot be approached, cannot be done. There is no form of vital pulp therapy that you can do in this case, right? Now, then another question from traumatology, and this question was slightly tricky, guys. Why? Very limited information was given. The child is 4.5 years old, presents to the OPD with a discolored 5-1. What is 5-1? So in children in deciduous teeth, we have 5, 6, 7, 8. So it's the first quadrant. So it's upper right central incisor, upper right deciduous central incisor. Now the catch here is the patient is asymptomatic. Okay, fine. History of trauma 6 months back. What is the treatment? Now, usually in child patients, if they're asymptomatic, slight discoloration is there, we just wait and watch, right? But wait and watch was not there in the options. Right. That's one catch. The other catch is you've waited. Yeah, like the history of trauma is 6 months. So that's pretty long, right? Usually you wait for 6 months. Wait and watch is around 6 months only. So that's another hint the examiner is saying that, guys, here, this tooth might be an asymptomatic necrotic, kind of tooth, right? So what do? Can you do IPC or pulpotomy? You cannot. That's a vital pulp therapy procedure, right? In all likelihood, this tooth is undergoing necrosis, right? Extraction, I mean, there's still a good 1.5 to 2 years for the permanent tooth to erupt, right? So let this be used as a space maintainer. Pulpectomy, I think the most appropriate answer, if not the ideal answer. You know why? Because I would have still thought that wait and watch would be a better answer here, but that was not in the options. So I'm going with pulpectomy here, guys. Right? Again, pulpectomy is not the ideal term here because the pulp is necrotic now, which it would be. It's been quite a long time now. Then an endodontic procedure or something like a debridement is a better term than pulpectomy, right? Pulpectomy is usually a term for doing RCT of a vital tooth. But anyways, I feel out of all these options, if wait and watch is not there in this kind of a question, you go for pulpectomy. Then another uh, trauma-based question. Patient, this is relatively simple. Patient presented with complicated crown fracture. So dealing with like a Ellis class 3, right? Pulp is exposed. And the tooth is vital and it is an open apex, right? What is the suggested treatment? What is the suggested treatment? So very simple, guys. Um, since it's an open apex, it is vital. I would want root end formation to take place naturally, right? So I would want apexogenesis to take place. So I would want to do a vital pulp therapy procedure. So I would want to do a pulpotomy, isn't it? So let's see what are the options. IPC, there's no point. Pulp is exposed. So indirect pulp capping cannot be the answer. Pulpotomy, pulpectomy, extraction. If I do pulpectomy, I would leave the tooth with an open apex. Root end formation, maturation will not take place. I would want myself and the patient, I would want us to give a chance for the tooth to stay healthy, right? So I would go for pulpotomy here, right? While assisting, new question now, while assisting for delivering an all ceramic restoration, the chair side assistant got accidentally exposed to HF, hydrofluoric acid, right? Hydrofluoric acid you use for etching the tissue surface of your ceramic restoration. And not necessarily, zirconia restoration, but basically your, Emax and lucite based anterior aesthetic um, ceramic restorations. Now, what is the antidote? So, first of all, guys, what do you do if you or the assistant or any other clinic staff gets exposed to a strong acid like HF? You obviously rinse it copious amounts of water, and then you can use calcium gluconate gel. That's the answer, guys. Here. So you had options as sodium bicarbonate gel. All were gels: sodium bicarbonate, potassium hydroxide, calcium hydroxide, and calcium gluconate. The answer is calcium gluconate gel. New question. So, yeah, I'm sure many of us would not be knowing this answer. This is a new question. Then another new question is following bleaching. The statement went like following bleaching, there is compromised bonding and addition and polymerization of composite on account of what? On account of residual oxygen that is there, right? Which of the following can you use to manage this problem of residual oxygen so that you get adequate bond strength with your composite, right? Now, normally this question previously, again, new question. This question previously has come straight pick from Ingle, where the answer was catalase, right? You could, expose the bleached tooth substrate to catalase in order to, remove the residual oxygen, or catalase was not there in the options. The other form in which this question usually comes is how much do you wait? You wait for at least 1 week and preferably for 2 to 3 weeks, right? These are all the controversies that are going on, right? However, again, this question was a new question. So, guys, here you basically use an antioxidant like the answer is sodium ascorbate, right? The other options were citric acid, EDTA, and sodium bicarbonate. Right, guys? The answer is sodium ascorbate. Again, I do not expect many of us to know this because this is a new question. 59-year-old male was advised to undergo root canal treatment of a given tooth. It was not mentioned which tooth. Not mentioned in any detail, whether it was a pulpectomy, whether it was irreversible pulpitis, a necrosis, necrotic tooth. Simple root canal treatment of any tooth, right? He's on aspirin of a dose of 75 mg per day for stable angina. Now, before endodontic procedure, what do you advise? Option A, do you advise him to stop aspirin for 3 to 4 days before his appointment of root canal? Do you advise him to stop aspirin 4 to 7 days prior? Do you advise him to stop aspirin 7 to 10 days prior? Or you don't need to do any modification? No need to stop aspirin, or I think the exact words in the exam were no need of any modification in the protocol. That's the answer, guys. Aspirin does not, there are two things here, right? First of all, when you're doing pulpectomy, it's just removing the blood supply of the, you know, of the tooth, right? You're not causing any bleeding in a major blood vessel. That's one. The other issue is when you're doing giving an inferior alveolar nerve block to secure anesthesia in say, a lower tooth, then there can be a problem. Sometimes there's a bleed. Then what do you do? Then do you stop aspirin? Again, no, because it has been shown that aspirin does not significantly increase your INR or your BTCT, right? So this kind of a dose, especially this small dose of 75 mg per day, is pretty okay. And you do not need to do anything, especially for an endo procedure, right? Now, next question, again, a new question and slightly controversial. Why? I'll tell you. Beryllium and gallium are added to base metal alloys, right? Because of various reasons. One is beryllium enhances the castability of alloys, while doing casting. It reduces the melting point of certain components. That's one. So it improves the handling properties. Gallium also is added because of certain functions it does. Now, what can they cause? So the options were cytotoxic. Are they cytotoxic? Do they have the potential to cause cancer, carcinoma? Genotoxic, hypersensitivity, right? Now, guys, very clearly, Phillips writes that beryllium is a known carcinogen. Although in vivo it has not been shown, like experimentally it has been proved it's a known carcinogen. But in vivo it has not been shown to cause cancer. Again, controversy. That's controversy number one. Controversy number two is that gallium itself is pretty biocompatible. So where does gallium fit in with beryllium? Isn't it? So I feel there's a slight, I don't know, some issue with the framing of the question here. But as far as the most appropriate, if not the precise answer goes, most appropriate answer goes, I would go with carcinoma because very clearly, beryllium is clearly written in Phillips that it is a known or documented carcinogen. When you talk of berylliosis, guys, berylliosis is also, it's a kind of a chronic condition. Where does it fit in? Does berylliosis fit in hypersensitivity, genotoxicity, cytotoxicity? Not exactly. So that's why I am going with carcinoma. Right? Again, slightly controversial, but as of now, as of today, I'm going with carcinoma. If there is any other change in my answer, I'll definitely post it on the YouTube channel. Again, new question, guys, applied question. Specific heat of dental materials has got relevance to which of the following procedures? Right? Spruing, casting, annealing, investing. So basically, what he's saying is like when you're, say, for example, you're creating a wax pattern, right? Your crucible former base, your wax pattern is sprued and then it's invested and then it's sent to the casting and then it's annealed, right? So specific heat of dental materials will have direct relevance with which of these processes. What is specific heat, guys? It's the amount of heat, quantity of heat right? Say in calories, to raise the temperature of, say, 1 gram of a substance by 1 degree Celsius. That's specific heat. Now, when you're doing sprueing or investing, when you're dealing with a wax pattern, right? Not not great significance or relation with specific heat. When you're doing your when you once you've burnt out your wax pattern and now you're doing casting, you're using some alloy, right? Base metal alloy, gold based alloy, whatever, or titanium. Now you're supposed to heat it to a particular temperature, right? And the heat source, whether you're using a acetylene gas torch, you're using some butane propane mixture, you're doing some laser, you're doing plasma arc, or you're using lasers for titanium casting. You definitely want to know how much of heat I require to raise the temperature of my alloy so that it ultimately melts, right? So I think casting, again, new question, applied question, casting is the answer here, right, guys? The process of casting, heating the alloy and then casting it into this investment mold cavity, that has got direct significance with specific heat of dental materials. A totally applied question. Again, those of you who've done this correctly, and you've maintained that momentum throughout those 3 hours with other subjects also, expect a good rank. Then, guys, difference between adsorption and absorption, again, applied and new question. So, guys, the options were pretty interesting. One option was adsorption deals with solids and liquids. Absorption deals with gases only. Then the other option was adsorption is a surface phenomenon, whereas absorption is a bulk phenomenon, right? The entire whatever is getting absorbed into the body, it gets absorbed into the body of the substrate or the absorbing substance in the bulk or in the volume of the body, right? And whereas adsorption is a surface phenomenon. Now, this is a true statement. So this was the answer, guys, here, right? This was the answer. Then, just for your information, what was the next option? The other option said that adsorption is related to surface texture, absorption is related to surface energy. This is not right because even adsorption is related to surface energy, isn't it? More is the surface energy of the substrate, the more is the tendency for it to adsorb or absorb material. So it's not like just related to surface texture. It's even adsorption is related to surface energy. So again, this was a wrong option. D option I don't remember, but yes, the answer is B. Adsorption is a surface phenomenon, where absorption is more of a bulk phenomenon. It deals with the diffusion of the entire substance within the body or the bulk or the volume of the substrate. Right. Now, this question was pretty straightforward, guys. A male patient reports to the clinic. He has a heavy occlusion. Heavy occlusion means heavy occlusal forces. He presents with wedge-shaped defects in the cervical areas of of the facial surface of maxillary premolar. The answer is abfraction, guys. The other options were erosion, abrasion, and gastroesophageal reflux disease. The answer is abfraction. Many a times we've discussed this, internally in our Telegram groups and everywhere. Then there was this image-based question, pretty interesting, guys, in which the examiner said that we're dealing with a mandibular first molar, right? We're dealing with a mandibular first molar, right? And uh, they were showing there was this X-ray in which files were not there. It was showing an obturation, but the X-ray was very similar. The mesial root had got 3 separate canals. So you had a middle mesial canal, isn't it? Apart from the mesiobuccal and mesiolingual, you had a MM canal, middle mesial. And you had 2 distal canals. 2 distal canals can be present usually also, isn't it? Almost 30% of mandibular first molars have 2 distal canals. But it was very clearly showing 2 different outlines of 2 different roots here. So one was a radix entomolaris. So the answer was simple. The case was that of a middle mesial canal and radix entomolaris. The other options were like only middle mesial canal, C-shaped anatomy, and so on. So the answer was simple, guys. Middle mesial canal and radix entomolaris. That was the answer, right? Okay, controversy. Which of the following is caries promoting? The options are vanadium, selenium, lead, molybdenum. Very confusing. Let me be very clear. Molybdenum is caries protective. This is an original 1987 article that I saw that says that molybdenum is caries protective. What about caries promoting? Both selenium and lead are caries promoting. Now, both are there in the options. Which one to go for? Everywhere in every reference, selenium comes in general, selenium is mentioned before lead. So I'm going with selenium, guys. The selenium is caries promoting. Controversy, but yes, that is my final answer. All right, good one, guys. We've done this in our routine lectures also. Clinician is restoring the lower left mandibular left region. It's a 3 unit restoration, so basically a 3 unit bridge, metal ceramic bridge. That is what was mentioned in the exam, right? Now he has decided that I want to take the impression. He's done the crown prep. He decided that I want to take the impression with an elastomer. And the catch here is that the patient is a gagger. He has got a solid gag reflex. So obviously, you would want to choose a material which has got the lowest, least, the lowest setting time, right? Now, I've shared a screenshot here of our notes. I always do this in my live lectures also, rapid revision also. We always do this table of all these four elastomers, the setting time in the oral cavity. If you see, addition silicone is no doubt the answer. The setting time is total right from the start of mixing, 5.9 minutes, right? The polysulfide has got the highest, longest setting time, not recommended. As it is, it's no longer used. Then condensation silicone and polyether have roughly 8 to 9 minutes. So again, you're not going to use this in a gagger, in a patient who's gagging, right? So the answer is simple: addition silicone, no doubt. So again, clinical based question, or you can actually say that just they're just trying to create a clinical scenario, but ultimately the question is hardcore dental materials, isn't it? Brush heap structure. Now again, controversy. Why? I mean, guys, brush heap structure is a is the appearance, is the microscopic appearance of hydrocolloid. So both agar and alginate, isn't it? But more specifically, it's agar, right? If you see the table of Phillips, then they write the composition of agar. They write agar, brush heap structure. When they write the composition of alginate, they write sodium, potassium, triethanolamine alginate, which is basically a reactant, right? Which is going to react with calcium sulfate to give you calcium alginate. So yes, ideally speaking, both will show a brush heap structure, but better answer is agar, right? So brush heap structure, agar. That's the answer. Again, slightly controversial, but I mean, I think most of you would have done this correctly because the first thing that comes to mind for a brush heap structure is agar, right? Now, this is again a tricky one. I've done this a lot of times with my students. Which of the following is true regarding the order of linear contraction, right? Now, guys, there is this very important graph in Phillips, which I always do with my students, in which there is this order of dimensional stability. Always remember when you're dealing with impression materials, elastic recovery is one thing, or plastic deformation is one thing. That is, you take the impression, you take it out with a snap. Then which material shows the best elastic recovery versus that order that you follow. And then there's another thing, that is this linear contraction or dimensional stability. That is, you take the impression and you just leave it on the bench without pouring it, and then you see. So in that, the best, or the one which has the best dimensional stability, or the one which shows the lowest linear contraction, is addition silicone, then polyether, then polysulfide, and the highest condensation silicone. So there was this option. I've written the answer straight away, guys. This is the answer. Addition silicone. If you, it was actually given in descending order, maximum to least. But obviously, remember this. in this manner. So I think in the exam, the correct answer was the C option. And obviously the rest of the options were different permutations and combinations. If you know the concept, if you know the right thing, you'll think about it in your head when you see the question. And then you'll match what you think and what you know is the right answer with the option, right? So you just go and directly mark that option. So obviously the other three options were a permutation and combination of this. The answer is this. So, which is true regarding order of linear contraction. The lowest addition silicone, then polyether, then polysulfide, then condensation. Right, guys? Okay, again, slightly controversial. Hardening solution or hardener is added to which of the following? Now, guys, if you see, um, this is again a screenshot from our notes. If you see the composition of agar, you add borax to add strength, but borax is a gypsum retarder. So you, in order to counteract the effect of borax, you add potassium sulfate, and that's the gypsum hardener, right? So borax provides strength, but it's a retarder of gypsum. So you add a gypsum hardener, potassium sulfate. So by this logic, again, the best answer is agar, isn't it? However, in alginate also you're using a gypsum hardener, and that's a different. That's potassium titanium fluoride. But again, guys, more classical, more standard answer is agar. So again, in this question also, if you have both the options, go with agar, right? Next question. This is simple, guys. A composite restoration was done in the maxillary anterior tooth. The clinician decided that, I want to use a bonded abrasive and do some good finishing and polishing. Now, which of the following is the strongest bonded abrasive? So this was a whole story, to give a clinical scenario to the question. But this is basically, again, hardcore dental materials. Again, this is a screenshot from our lectures and from our content. We've done this. I do this every time. When you talk of bonded abrasives, you've sintered, you've rubber, you've resin, and you've vitreous. The strongest is sintered, right? So this is actually a repeat question. No doubt about this. So sintered abrasive is a bonded abrasive, which is the strongest. Okay, great question. New question, and I don't expect many of us to do this correctly. But again, I don't know how. I think I'm very happy in the sense that this kind of topic from the chapter of finishing and polishing materials was never covered. I always cover this since the past so many batches. I always make it a point to cover truing and dressing. But the examiner was so smart this time that I think even those who've read this have got very high probability of marking this wrong. I'll tell you how. So again, the question was formulated in a clinical scenario that following restoration, the clinician decided to do finishing and polishing, and he realized that, I would do truing and dressing of my abrasive instrument, right? To give the maximum good finishing and polishing to my restoration, right? So, so it was mentioned in the question that truing and dressing of the abrasive instrument was decided to be done. Now, which of the following statements is true regarding dressing, not truing? So, which of the following represents the dressing procedure? That was a question, guys. Now, first of all, let us understand what is truing and what is dressing. Now, what happens is that, again, this is the screenshot. So you realize here, guys, basically what happens is that you have an abrasive like simple diamond burr over a period of time. If you're not cleaning it, it gets clogged with debris, right? With cut tooth structure. And sometimes it starts to kind of, because of excessive pressure on one side, it starts to have some run out and eccentricity while rotating. So in order to maintain the instrument, it's basically doing, service, like you'd service your car, right? You want to maintain it. So in order to service to maintain your instruments, you do truing and dressing. So truing is you run your abrasive instrument against an even harder substrate. Number one, to ensure that it rotates in a perfect center, right? Without any eccentricity around, or with minimum eccentricity around. That's truing. Dressing is what? Dressing is reducing it to a particular size and shape, right? For example, if this is the shape, original shape of my, instrument, I want to kind of make it pear shaped, right? Flame shaped, so that I can approach, my interproximal areas. That's dressing. That's one purpose. And second purpose of dressing is to kind of remove the clogged debris, which is clogging and reducing the efficiency of my instrument. Now, see how the examiner wanted to confuse you. First, so what is true about the dressing procedure? There are two statements which are true regarding the dressing procedure. One is to remove the clogged particles. So that's true. So that can be an answer. The other is to reduce the size to a particular size and shape. Like, you know, the instrument originally is like slightly bigger, and then you want to create it into a flame shaped size. So to reduce it to a size, particular size and shape. The option that the examiner gave here, which was very similar to the right option, was enlarge it to a given working size and shape. It's not enlargement, it's reduction. So again, this is like half right. So this cannot be the answer. You understand? This cannot be the answer because you reduce it, not enlarge it. The option had said enlarge. So again, this cannot be the answer. Preventing eccentricity and run out of the rotating instrument is screwing. It's not dressing. Obviously, promotion of blinding. Blinding is clogging of the debris. That obviously cannot be the answer. So the answer here is to remove the clogged debris. Right. New question. And even in a new question, the examiner tried to really confuse us. Right. So that's the answer. Removes clogged debris or clogged particles. All right. Cusp capping is considered. Now, if you remember, this is second year, preclinical, conservative. Cusp capping is considered when the outline form, it's considered. It's not definitely done. So you do cusp capping, definitely do cusp capping when the extension of your outline from your primary groove to the cusp tip is greater than 2/3. You definitely do it. When it's considered when it's half to 2/3. So that's the answer. And it's usually not done when it's less than half, right? So the answer was simple, guys. It is considered, right? That was the catch here. When the outline form extends from the primary groove to the cusp tip, half to 2/3 the distance. So that's the answer, guys, right? Okay, resistance to cutting of enamel with a bladed hand instrument is seen with a very hard, strong, solid enamel, right? So that's gnarled enamel, right? Then again, another question which is very favorite of mine. Clinically, how do you differentiate between a white spot lesion of early caries versus that of a hypoplastic lesion? Guys, incipient carious lesion, white spot, you hydrate it, it kind of disappears. But a hypoplastic, because of a hypoplastic lesion, a white spot due to a hypoplastic lesion is not that affected by drying or wetting procedures. It still appears opaque white, right? So that was the answer, guys. The rest of the options did not make sense. It was straight pick language as it is from Sturdivant. So white spots of initial caries or incipient caries kind of disappear on hydration, and the white spots of hypoplastic lesions are not that affected by drying or wetting with water, not setting. It is actually wetting. Wetting with water. Right, guys? Then it's a very simple question, guys. A 9-year-old child fell in the park. His mother wants to take him to the clinic. He got his tooth avulsed. Upper left central incisor got avulsed. Right. The mother wants to take him to the clinic, and she wants to know in which solution should she immerse the tooth. The options were saliva, saline, milk, and tap water. Obviously, milk is the answer. You all know Hank's balanced salt solution and Viaspan are the best. Amongst Hank's balanced salt solution, Viaspan is the best. The next in line is milk. Right. Next question. In the electroforming process, to obtain an electroformed dye, the question was the impression surface is covered with silver powder. Now, this process is basically metallizing, guys. Right. So, if you want to create a dye which is very abrasion resistant, right, when you do your carving of your wax pattern on it, you're making your inlay or your coping of your metal ceramic or all metal crown, you don't want your cover to abrade the surface of the die, right? So you want to cover it with metal, plate it, electroplate it, or electroform it, right? So you first, the impression surface is not conductive. You want to first make it conductive to electricity, right? For that, you do the process of metallizing. And what is that? Just kind of sprinkling silver or metal powder onto the impression surface, right? That particular tooth or teeth, you want to electroplate. So the options were, what is the purpose of doing the sprinkling of silver powder that is metallizing? And the options were tricky. One was to increase abrasion resistance. Yes, it is ultimately. But what is the immediate purpose? The immediate purpose is that you want to make it conductive to electricity so that you get that throwing power to kind of add whatever thickness of metal you want to on the surface, on the tissue surface of the impression. So the answer was to promote conduction of electric current. That's the immediate purpose. And ultimately, obviously, when you retrieve you pour it in your, gypsum product and you retrieve it, you get an electroplated, abrasion resistant die, right? So that was not the answer. One of the options was to make the die abrasion resistant, to make the die hard. Yes, that's true. But the immediate aim of metallizing it was to make it to promote conduction of electric current. And that's the answer. Right, guys? Okay. So, I'm sitting in my clinic, next question, and I realize that my addition silicone material is not setting properly. And upon investigation, I realized that my assistant, when mixing it, is using latex gloves to handle the material. So, what's the problem? The answer is straightforward. Basically, latex gloves have sulfur. Sulfur released from the gloves acts as a poison to platinum, slowing the reaction. You all know the addition polymerization reaction of addition silicone. The platinum is the catalyst. Palladium is the hydrogen scavenger. Platinum is the catalyst. A sulfur kind of plays games with the platinum, and that kind of retards the reaction. Right? So that's the answer. The rest of the options were like hydroxyl ions are being released and they're kind of, interfering with the setting of the base paste. Doesn't make sense. Then there was an option in which water powder ratio is hampered. I mean, we're not mixing the addition silicone with water, right? Okay, which of the following has lowest modulus of elasticity? Time and again in Rotaloy's chapter, guys, it's the night-eye, right? The option was not straightforward night-eye, it was M night-eye, martensitic night-eye. Anyways, this was the answer. Right? The other option was cobalt, chromium, stainless steel, beta titanium. The answer is night-eye, no doubt about this. Lowest modulus of elasticity or the least stiff. Right? Which is the latest type of beta titanium alloy used in orthodontics? Obviously, Dr. Kunal will be doing this, but so I don't have much details on this, but whatever I could find out, it's basically nothing but a trade name. CAN. CAN was one of the options, and I think that's the answer. Still, I would request Dr. Kunal to kind of confirm this. I'll ask him. Okay, disadvantage of using ultrasonics to perform root end prep. Guys, straight from Cohen, there's this very high chance when you're using ultrasonics, no, to do your following your root end resection, you want to make a simple class 1 cavity, right? So that you can get the root end, so that you can fill it with the last 3 to 4 you can fill it with MTA or biodentate, right? Root end filling material. Now, the problem with ultrasonics is that they have this tendency to cause micro cracks or micro fractures on the root. So that's the answer, guys. In fact, one of a related question to this came in last INI also, in which they said that when you're using ultrasonics, you should use it in a low power setting. And the reason is again the same, to prevent or to reduce the incidence of microfractures. Okay, this is a very old question. Class 2 restoration. There is a gingival overhang or cervical overhang. It was an mesio-occlusal prep on the maxillary first premolar. We all know this. We do wedging, isn't it? Why? Because we have a mesial marginal developmental groove. So if you don't do wedging, you will get a cervical or a gingival overhang. So the reason was mesial marginal developmental groove. This is an often repeated question. Oh, referred pain is carried by which nerve fibers? Guys, This is a straight pick from my textbook of Endodontics by Dr. Aishwarya Kaushik. If you have not bought it, please buy it. Right? This is you can order it online from Flipkart, Amazon, etc., etc. And obviously, this is a straight pick from Cohen. This is a straight pick from my lectures. The answer is C fibers, guys. So C fibers is the answer, guys. Here, referred pain is basically what your C fibers at the you know um, at the trigeminal nucleus. They kind of converge from different areas, and then you don't know. So, for example, the C fibers from the auric, this temple area, and the posterior superior alveolar nerve supplying the innervating the upper molars would be converging onto the same area of the trigeminal nucleus, and you will not know which the pain is coming from where. That's referred pain, isn't it? Law of convergence from different areas, right? And that is the C fiber is a straightforward answer, guys. Right? Thermoplastized obturation technique is contraindicated in. Guys, I mean, thermoplastized is great for backfill. It's great for internal resorption cases. It's great for C-shaped cases, but you should not be using it in open apex, right? Because you don't have an apical constriction, and you would end up injecting the GP in the periapical area. So obviously, it's contraindicated in open apex. Simple, straightforward. Which is considered a disadvantage of inlay wax? Obviously, high thermal expansion, guys. Flow is good. Rigidity is not a great forte of inlay wax, right? So I do this. I always do this. This is a screenshot from our notes and lectures. We always discuss this very high thermal expansion, coefficient of thermal expansion of inlay wax, which is not great because you have to you have to invest it immediately if it's kept lying on the bench or in the clinic due to temperature changes, it'll completely distort and so on and so forth. So thermal expansion is definite disadvantage of inlay wax, guys. Right, guys? So I hope, yes, a lot of questions. I mean, by the end of, there's so many questions that came from DM and endo and cons, especially DM. And of course, endo, as usual, the trend was, trauma, trauma, so much trauma. DM, good coverage of finishing and polishing, waxes, you know, basic concepts, confusing new things, newer questions, finishing and polishing. I mean, truing and dressing. I mean, I've been teaching this for so many years, and this is the first time that I got a genuine question from truing and dressing, right? And I don't think anybody, pays so much attention to truing and dressing and these topics. So I was actually very happy that finally what I believed in actually came, but unfortunately it was too tough a question. And I still feel that many of you would have either left it or gone wrong with it, but that's okay. Um, Polishing of ceramics. Usually it's the polishing of composites that they ask, isn't it? This time they asked about polishing of ceramics. So again, a new question. So all in all, yeah, pretty tricky, tough paper. So yeah, that's it, guys. Um, Take good night's sleep, and tomorrow is a new day, and just keep working hard, guys. I mean, it's tough, but that's how it is, right? That's how it is. We keep believing in ourselves. We keep up the faith. We keep taking our God's name, and we just keep working hard, isn't it? That's the only thing that we can do, and I think that's the best way forward, right, guys? So I wish you all the very best, and thank you, guys.
Hello, and I should say not even good evening. It is almost night. It is what 10:50, and we are live here doing the recall of questions pertaining to the subject of prosthodontics that came up today in the NEET MDS 2025 paper. And I'm Dr. Ruchi Raj, your prosthodontics mentor. And as always, my first question to you, like all other mentors, is how was your exam? How was your paper? Do let me know in the chat section. How was your exam? And how was your paper? And how was Prostho for you specifically? I have got a mixed bag of reviews from different students. For most of them, it felt moderate. My perception of paper after seeing these questions is that sure, there were a lot of recalled, I should say, repeat PYQ questions or questions that are apparently something that you've seen before. But the questions that were new and the questions that were difficult were genuinely very difficult, to the point that by seeing those questions, I could feel that even if someone would have attempted these questions, the chances of them being wrong are much more. So, in that way, the paper was, or I should say, the paper is diverse. A moderate paper, I cannot call it a very easy paper, also, and not an extremely tough paper. If you have prepared well, you have a decent chance of scoring and getting a good rank in this exam. As always, I also believe an easy paper is never a very good idea for any entrance exam. It is highly competitive. Your margin of error becomes very less. So, such a moderate paper with these questions that are slightly on the difficult end, where you, if you have read, you're going to get them correct. They're going to decide what rank you get and whether you get a better rank or not. So, at 10:50 in the night, without wasting any further time, let us begin to the questions pertaining to prostho. Now, from implants, very straightforward, two questions were there and relatively easy questions, something that we have done before. And while teaching implantology, I take it towards the end of my live sessions. I try to make it concise and to the point because it is a very diverse topic, and I try to brief you with the things I feel you should be ready from implants. And I've always maintained and said that beyond this, if anything comes, it is going to be difficult for any other student. It is going to be difficult for everyone. So you can leave that much out, but these are the basics that you should know. And from that basic, we have this very important question and a very easy question, I would say now. The minimum distance between two implant guys, is it 2 mm, 3 mm, 4 mm, or 5 mm? Now, the correct answer to this is the minimum distance that we must keep between two implants is 3 millimeters. We have time and again discussed these different points in the anatomic considerations. It is there in my recordings, it is there in my live sessions, it is there in our notes, and we have mentioned what it should be. Like we have mentioned here, with even the reference from mesh, the minimum distance between two implants is 3 millimeters, and between natural tooth and an implant is minimum 1.5 millimeters. So relatively easy if you have done these numerical questions from your implants. So that was the first question, which was regarding the distance, right? So a moderate question, PYQ, basics of implantology. Now let us come to the second question. A 55-year-old controlled diabetic patient, see what is mentioned here, controlled diabetic patient is in need of implant treatment. What will be the most important deciding factor? Now this is something that we have even discussed before. When something like what is the single most important, what is one advantage, even if the option mentions all of the above, that is not the answer the examiner is looking for. They are looking for that one point. So out of all of them, obviously all four of them are important when we look at a patient during history. But what is the one factor that is going to be a deciding factor? So the main thing that you should keep in mind while reading this question is patient is having controlled diabetes. Now, duration of diabetes, will it be important? Will it be the single most deciding factor? Medication history, dietary habits, or density of bone? So the answer according to me over here, the single most important deciding factor, whether you can go ahead with implant here or not, is the density of bone. That will give you a clearer picture whether you can execute this treatment. And I have always suggested our students during multiple of our sessions, I can say, I think if our students are joined here in live, probably they would want to actually confirm this. I've always maintained and said that you should try and cancel out the other three options. So if you look at the other three options, would just the duration of diabetes give you a clear picture, yes or no, whether you want to place an implant? Would just the medications probably guide you, or would just the dietary habits guide you? No. But just by even looking at the density of bone, you would be able to figure out significantly better than the other three points mentioned here that whether or not you can go ahead with implants. That is why the correct answer here is option number D, that is density of bone. So two questions from implants, and implants always has been something that has been tricky. Either something very weird or tough comes or something very basic. But with implants, as we have mentioned in notes, even in the last week, we shared a very small snippet of the most important points from implants for our students in the Telegram and different groups. So from implants, the basics must be ready and something that you should be knowing. Now, let us come to maxillofacial. And I'm also watching at the different points that you're mentioning in the chat, right? Now, question number 3 from maxillofacial prosthesis, and I like this question. The reason is that we've studied this, but it is just an extension of it. So the point that we mentioned that questions are always picked from previous year topics. This is an example of it. Now, we have seen quite a bit on the rotation that or the deviation that happens in hemimandibulectomy. The questions have come, deviation occurs towards which side? This is a step beyond it, where it is asking in hemimandibulectomy patients, in patients with hemimandibulectomy, the jaw deviates on one side and it deviates. We know that this was one MCQ question, it deviates towards the resected side. Right? So this was the question. Now they don't step ahead of it last. What is the muscle that is responsible for it? So students, this I'm assuming would have been slightly difficult for you to attempt over here. What is the muscle that is responsible for it? So this mandibular deviation that we see, it is due to the uncompensated influence of the contralateral medial pterygoid muscle. I'm sure there is a plethora of muscles, actually the muscles of mastication, if you see bilaterally, they are responsible for the balance that is there on mandible where the forces are nullified against each other. Now imagine on one side if the mandible has been resected and we have lost it because of the contralateral pull of the internal pterygoid muscle, which is a medial pterygoid muscle, and even the contracture of the scar tissue that is responsible for the deviation of the mandible. The mandible will deviate to the resected side, and we have discussed this in our notes, even exactly on the first page of our notes where we have mentioned, see how even frontal rotation of mandible occurs. There's a rotation point that occurs in mandible and how the segment deviates and moves, right? So this is something that was discussed prior. And the answer to this is your medial pterygoid. I'll take just a moment to see if any comments have been added up. Now, there is some controversy, or I would say confusion over here. The reason is that it is not just one muscle that is responsible for it, even the depressor group is involved. So, to pinpoint one muscle is difficult, but when you go through literature, primarily what is the muscle that is responsible for it? If you have to pick one, consistently, even it has been mentioned in literature, Robinson's article, if you see, consistently it has been mentioned, it is primarily due to the pull of contralateral medial pterygoid. The suprahyoid group of muscles, other muscles are also involved. It is not just the role or function or an effect that comes out of the function of just one muscle, but what is the major contributing muscle? The one answer that we need to pick up here, it is medial pterygoid. So I'm seeing some of our students here, some of them are sharing shocked responses. Okay, I was assuming many of you, or maybe most of you, would have marked lateral pterygoid. Did you all mark lateral pterygoid? Can you let me know? Right? I'm assuming most of you would have marked lateral pterygoid, but the answer here is medial pterygoid. So for question number 3, hemimandibulectomy, jaw deviates on the resected side. This is the previous year question. Muscle responsible for this is medial pterygoid. Now, question number 4. 68-year-old male patient with Kennedy's class 3 situation, what is the nature of support? Now we know Kennedy class 3 situation means what? Something that is bound anteriorly and posteriorly by an abutment. So it is a abutment bound space, and we have studied it. Very pretty simple and easy question that generally class 3 situations are tooth supported cases. So there were other options, whether it is unilateral distal extension or bilateral distal extension. We know that this is class 1 situation. This is class 2 situation. Tooth tissue supported is exactly both of these only, class 1 and class 2. So we are left with option number A, which is tooth supported, which is classic of Kennedy class 3. And a very easy question, I would say, a very basic question. Kennedy class 3 situation is a supported case. So question number 4, very basic question, I am sure, and I hope you have not made a mistake here. This is just a snapshot of the parts from notes where we have discussed it, where we have even described the different points of tooth and tissue supported RPD and even the different differences between them. Now, let us come to question number 5. A 45-year-old male patient with missing teeth in upper jaw from 1.4 to 1.8 and 2.4 to 2.8. So essentially a distal extension case here. What special impression technique will be used for this Kennedy class 1 situation? Now, for this Kennedy class 1 situation, what special impression technique would you use? Mucocompressive, open mouth, closed mouth, or altered cast technique. Now, there is a little bit of controversy over here in this situation and this question. They have mentioned specifically it is a Kennedy class 1 situation, and what is the special impression technique that we use over here? The special impression technique actually that we go ahead with, which we have described even in our lectures and notes, is generally these techniques, which are called your dual impression techniques, right? We take an anatomic impression, we take a functional impression, and when they relate both of them, that is called as a dual impression technique that we do in cast partial dentures. And it's these either your physiological or functional techniques, or ideally, I should say, selective pressure should have been in your options. But I don't see selective pressure over here. But what we do after this special impression technique is what is called as an altered cast technique, wherein with the new impression that we have obtained, we alter the previous anatomic cast and obtain a new cast that is called altered cast technique. And I think over a period of time, people might have stopped saying only selective pressure and just directly relate the special impression technique of distal extension directly to altered cast, which is wrong. It should not be there. But out of the given options, and I've verified it with even a lot of students, nothing about about selective pressure or any of other dual impression technique was mentioned in the options. So the only answer that I can think of here, which we can mark here, is altered cast technique, assuming that they are trying to point out the entire process of selective pressure technique and then do altered cast at the end of it. Mucocompressive, open mouth, and closed mouth, they are not relevant over here because they are not the conclusive final impression technique for this Kennedy class 1 situation. The conclusive final impression technique would be a selective pressure technique only that we do, and then we do an altered cast after it. So this we have discussed at length in our videos, in our notes, and even mentioned here with good figures and images. So a little bit of an issue with the question, but if you are able to figure out, then you would have marked altered cast. Even this slight presence of mind is needed in exam, that maybe probably this is the what the examiner is trying to convey to me. And this is what even I heard, that this time this was more in paper, that there were some language issues and other such issues present in the paper, right? So when you get to understand the theme of how the paper has been set, you would be able to figure it out. I think that this is what the examiner is trying to convey. Now, very straightforward question. Theoretically, exactly one line is written, and the same has been put here as MCQ. Which of the following rest will eliminate the need for placement of clasp arm buccally? Essentially, it is trying to say that the class palm that comes on the outer surface of the tooth, we want to eliminate that class palm, or rather the need of that class palm would not be required in which of these rests? Intracoronal, interproximal, extended occlusal, or auxiliary rest. All the other three, actually, if you see, these are extracoronal ones that go with the direct retainer assembly. This intracoronal rest that is placed within the crown structure, which does not require the placement of an external class palm, is the correct answer. They can be precision, they can be semi-precision attachments, and they are used within the structure. They are prepared like an inlay onto the tooth, and they are present within the crown structure. They will eliminate the need for placement of clasp arm buccally or lingually or anywhere exactly, actually. So that is the correct answer. You can even easily cancel out the other options considering they all belong to one separate category. This is one separate category. Again, we have discussed this in our videos, in our live sessions at the beginning of direct retainers as well as at the beginning of the chapter on rest and rest seats. So I'm hoping you were able to solve this one. Now, another question from rest. In designing of rest for molar teeth, the marginal ridge is reduced by 2 millimeters to accommodate the width of rest. The line angle is rounded so as to. So the lengthier questions where they are giving out information, okay, so they are telling you the marginal ridge is reduced by 2 mm to accommodate the width of the rest, and the line angle is rounded so as to. So you just need to focus on this part. The line angle is rounded for what purpose? Better distribution of vertical forces, for better distribution of occlusal forces, reducing the impaction of food, or reducing the chances of fracture of metal at rest. Now, first of all, what we are talking about here is occlusal rest preparation in molars. We are talking about occlusal rest preparation in molars, and there are certain set of guidelines that we have discussed, written in our notes, in which it is mentioned marginal ridge is lowered by 1 to 1.5 or approximately 2 millimeters so that there is sufficient clearance for metal. If you don't do so, under the forces of occlusion, when the restoration comes into occlusion, under the constant forces of occlusion, the fracture of metal will occur at this point. Also, when you prepare this inverted triangular shape for the occlusal rest seat, you're supposed to round all of the line angles. For the simple reason is that metal will not be able to survive in sharp bends because they become points of stress concentration and it fractures. This is a simple, straightforward concept that we have learned from dental material and we employ it in ortho, prostho, everywhere. So it is universally applicable everywhere. Wherever there is metal, we generally make the junction rounded, whether it is the minor connector emerging from the major connector or anywhere else. If metal is coming, the junctions or the line angles are generally rounded. The sole reason for it is you don't even need to have a lot of plethora of information about rest. You just need to have this concept about metal and stress concentration, and you would be able to pick the answer. That is to reduce the chances of fracture of metal at rest. The line angles will also be rounded. We give that clearance also so that the metal does not fracture. So eventually, like we have discussed in our classes before, where we have hammered it into your head, that look, out of everything from rest, the specifications of the design criteria of occlusal rest are very important. How it is an inverted triangular pyramidal shape. The depth of the rest seat at the central fossa is 2 to 2.5 millimeters. At the marginal ridge, it is 1 to 1.5. It has to be a positive rest seat. It does not slope out, and a lot of other different criteria. We explained it with figures, mentioned it in our notes, all of this, right? Even showing how fracture occurs. So all of this is essential and important. So what we were probably, or I would say what uh, I was banking on, that these are important topics and these are the trends and this is what we should be focusing on. Essentially, it is true. That is how papers are made. Previous year topics are important. Now, in the case of long-standing completely edentulous patient, The continual mandibular ridge resorption will lead to what? Again, a long, lengthy question. But answer is very simple. So alveolar ridge will become more convex and thereby increases the support. Do you think with ridge resorption that would happen? Ridge would become convex? I don't think so. So that is wrong. Attachment of mylohyoid muscle moves anteriorly, which results in anterior dislodgement of denture. If at all anything happens, it moves superiorly. It does not move anteriorly. So that is wrong. Mental foramen is located near the crest of the ridge, becomes vulnerable to pressure. That is the correct answer. And mandibular ridge narrows down posteriorly. No, mandibular ridge in fact widens posteriorly. So the correct answer here, the age changes that are seen in bone and in mandible particularly, is that mental foramen comes superiorly, becomes vulnerable to pressure. We have described these age changes and examination in complete dentures, even discussed Recall and scoop technique also, which I still hope in future is a potential question, or the different age changes that we see in mandible. Again, a very important topic from Prostho. So just a second. Now, I am thinking you all are maybe waiting for the selection question. Am I right? A lot of you might be waiting for the shade selection question. I've included it. I'm also going to give you an explanation on it over here. Contraindication of resin bonded FPD. So resin bonded fixed partial denture, very straightforward contraindications, deep bite or flared anterior teeth. All of these are contraindications. Is open bite, cross bite, bilateral cross bite a contraindication? No. So very straightforward answer, deep bite. Or any occlusal interference anteriorly, or any occlusion that will probably lead to a protrusive interference would probably cause even a breakage of this FPD. So definitely deep bite here is the answer. Straightforward question. Resin bonded fixed partial denture, what could be a contraindication? I'm sure most of you would have uh, this answer correct. Now, this is something new. Preparation of tooth surface for before receiving the all ceramic crown. Now, what here exactly is asked? Whenever we do tooth preparation, ideally we are supposed to give a provisional restoration onto it. After the provisional restoration and when before delivering the final restoration during cementation. So after we remove the provisional restorations, we do tooth surface preparation. This preparation does not involve removal of enamel or preparing the tooth to a particular shape. We are not talking about that preparation. We are talking about preparing the surface of the tooth so as to receive the crown in a better way so that the life that cementation is increased and what is the ideal protocol of it. So there is some preparation that we do to the all ceramic crown also where we etch it, we put silane. There's some preparation that we do onto the tooth surface also. What do we do? So in that, there involves a step where we clean the prepared tooth surface with water and a paste of pumice. The problem here is they are asking the specific kind of pumice here, which I think it would have thrown a lot of you off. And I want to know what answer have you all attempted rather than mentioning A, B, C. It's difficult to figure it out if you can just write the option over here. Glycerin-based pumice, water-based pumice, fluoridated pumice, and non-fluoridated pumice. Now, there is a slight confusion here. The reason is that non-fluoridated water-based, or I would say non-fluoridated pumice along with water is ideally used for preparing this tooth surface. What do we mean by preparation? We clean the surface of the tooth with this paste of pumice and water. So if there is any remnant of the temporary luting agent that was used to lute the provisional crown, it would be taken off. And now you have a clean tooth surface over which you can do etching, bonding, and then cement the crown. So it is basically done to remove those remnants of, if at all, any provisional luting agent that are there on the tooth structure before final cementation. This is known to extend the life of that cementation of the crown. So definitely should not be based on glycerine or should not have fluoride. Rather, it should be not having fluoride, should not have any other flavor, should not have any of these things that remain onto the tooth structure. The problem here is water-based pumice and non-fluoridated pumice, because both of them could go correctly, but I would still pick my answer as non-fluoridated pumice for the single reason is, if I have to pick both of either of them, literature mentions non-fluoridated pumice with water. So water-based pumice then actually rules out, and non-fluoridated becomes a more specific answer for it, that it is implied or understood that pumice is always going to be mixed with water. So this non-fluoridated pumice will be mixed with water and then would be used to clean up the surface of the tooth. But a water-based pumice, again with water, not relevant. Plus, it misses out on the very specific point, probably that the examiner, by subsectioning pumice, is trying to ask is, would there be any addition, I would say, any additive constituent to this pumice? Should it have glycerin? Should it have any fluoride or not? That is what probably the examiner is dissecting and trying to ask and maybe understand in your response, that do you know that this pumice that is used to clean the tooth surface should not have any additive? So considering that mentality, I'm taking up the answer as non-fluoridated pumice. Still, if there are any changes, 99% I'm saying I'm not going to change my answer. Still, if there are any, we would always discuss it later on. So a very good question, I would say. And the answer is non-fluoridated pumice. And I'm assuming here, a lot of you would have answered water-based pumice. Even I felt sorry when I saw the question, but such is the case. Now, the question that I think a lot of you would be waiting for, shade selection question. And I think long ago, probably in the first year with DBMCI, when I was discussing shade selection, I very vividly remember mentioning a line. Even if you pick out papers from past 10 years also, you will see a question on shade selection. It is that important topic. I've solved it as a student. It still comes in varying forms in exam, and this time in a very tough form. I feel probably there will be very few students who would have gotten this correct. Even if you would have attempted it also, chances of you getting it wrong may be more. It is a tough question. It is actually a very tough question. Even we had to verify our textbooks once more just to get it correct and see whether the answer that I'm giving out here is right or wrong. So for this, you need to understand some things with me. So first, let us see the question. 30-year-old male patient received mandibular anterior all ceramic crown. He returns next day because his family has said that the tooth appears bluish. So the key important point here is tooth appears bluish. Which of the following is the reason? Dentist did shade selection in natural sunlight, right? Dentist did the shade selection in fluorescent light with red yellow intensity. So fluorescent red yellow. Dentist did the shade selection in fluorescent light with blue green intensity, and shade selection was done in incandescent blue green light. So specifically in this visual shade matching, we are talking about the different parameters of the light source. Now, theoretically, we are aware light source should be somewhere at 5500 Kelvin, and your incandescent light has approximately 3800 Kelvin, and your fluorescent light has roughly 3000 to 4200 Kelvin. And generally, a color corrected fluorescent light is what is more commonly used in dental laboratories where there is no direct or natural sunlight. That is generally what is there. Now, the problem here that is arising is because of the property which is called as metamerism. Metamerism is what? A restoration appears to have a particular shade or a match in a certain set of light, and in another set of light, the shade appears differently. Why is this happening? Metamerism is the perception of this color of the object depending on the wavelength of the light also that it is able to reflect here. Now, For that, you need to understand natural sunlight has a balance of the different wavelengths. That is perfectly the ideal situation in which you should do your shade selection. So this cannot be the answer because it is the ideal situation in which you should be doing your shade selection from 10 a.m. to 2 p.m. Now let us look at what exactly fluorescent and incandescent light is. Incandescent is generally, I'm just mentioning I for it, is generally the yellower lights, the yellow light bulbs that you have. And fluorescent are generally the ones that emit bluish light, right? So now, so from out of this, even if you have this basic knowledge also, you would be able to figure out that incandescent won't be giving blue-green intensity, neither would this fluorescent be giving red-yellow intensity. Still, with this, all of this information, if the shade selection was done in fluorescent light, in blue-green intensity, let me change the highlighter here because otherwise, how would we mark the answer? The correct here answer is option number C. If the shade selection was done in fluorescent light with blue-green intensity, the ceramic would be reflecting a lot of blue, and in that particular light, it would have seemed correct and it would have been matching the tooth next to whatever next to it, right? But when you go in natural sunlight, then that would be a more bluish shade that you would have selected because of its presence in the fluorescent light. You would have not noticed at that point, and then in the natural case scenario it would start appearing more blue. That is why the wrong shade selection happens. If you actually look at the table, I have even written down, I went through articles, I have written it down, the errors that can come in shade selection due to lightings is that in fluorescent lighting, the error that happens is it can make shades look more bluish, and in incandescent, it can make the shades look more yellowish. Natural light is something which is the more balanced light that you have, and in which you would have an ideal or a correct shade selection. So full spectrum LED or natural light is, I would say, or a color corrected LED light or a color corrected fluorescent light is something that is considered be a better light for doing shade selection. And fluorescence, blue, green, incandescent are your yellow and red. And keeping all of this information in mind, my answer here would be option number C. Shade selection done in fluorescent light with blue-green intensity has a chance that the tooth will appear bluish later on. It is a mistake that you can commit, and a very, very tough question. I have said it time and again, shade selection is a very important topic, but if I were a student, I probably would have even gotten it wrong. So definitely trying to understand here, and I completely sympathize with actually students. These are the kind of questions very difficult to uh, probably get them correct. I actually wanted to look at the responses that you have shared in the live chat, and some are saying it is a catchy question, and a lot of some are saying it was a tukka. Fine, if you got it correct, I congratulate. But this is a very tough question, and if you have gotten it wrong, don't worry. If majority of the students get it wrong, the question will not be a decider of ranks. Now, question number 12. Functionally generated pathway technique works on which principle? So what exactly is functionally generated pathway technique? This technique actually involves taking records of mandible in a dynamic way between the two arches where mandible moves in different kinds of excursive movements, and then we try to register it in a medium, most probably which is wax. So since it is trying to record the mandible in all of these different dynamic excursive movements, it is based on the principle which is dynamic occlusion. Your static, centric or protrusive Yes, static positional principles are, I would say, occlusion points are not relevant to FGP. FGP is relevant on dynamic occlusal pathways that the jaw makes while doing these movements. So 12, question number 12, FGP, dynamic occlusion. There is a PYQ pertaining to FGP and semi-adjustable articulator. And when we have discussed this, under the explanation of it, we have discussed how it is based on dynamic occlusion. So just a spin-off of that, but still a good question. And now, another question, very long, lengthy language and everything was mentioned in this question. We have tried to simplify it. Which of the following is correct with regards to finishing and polishing of ceramic restorations? Now, as Dr. Aishwarya mentioned, there's a proper sequence that is given in Phillips, and the general principle of finishing and polishing is first you do finishing, then you do polishing, applicable to all kinds of restoration. Finishing means reducing the bulk down, bringing it to correct anatomy. So first you do the finishing, then you do polishing. So that it would involve gross polishing, and then you involve the final polishing. There will be a ton of different instruments and rubber discs and burrs involved in all of this with different kinds of paste. After all of this is done, then you do the final glaze, which could be a natural glaze or it could be an overglaze. There are two kinds of glazing. Overglaze means an application of layer of glaze. Natural glaze means heating up the outer surface of the ceramic so that it only forms a layer of glaze over it, right? Now, out of all of this, if you see, what could be the correct answer? Apply overglaze or natural glaze before contouring? Definitely not. You cannot do it before. So that is wrong. Before is not correct. Again, apply overglaze or natural glaze before contouring, finishing, and polishing. No, you don't do it before. Apply overglaze or natural glaze after contouring, finishing, and polishing. Yes, most definitely. Option number C is the correct answer. Or you apply overglaze just after contouring. No. After you contour, you do need to finish it and polish it to even out all of the irregularities. These are sequential steps of finishing and polishing that one needs to follow. And definitely a good question. I would say a moderate question if you understand the basics of prostho, even the basics of finishing a denture, you would be able to pick this out just on the sequence of it, that we first do finishing and then only we do polishing. So if someone would have hammered you in clinics for finishing a denture and then only allowed you to buff it, probably it would be embedded in your head, hard chance, but still. So question number 13, very straightforward from Phillips and even the general textbooks of Prosto also. And the correct answer is you first do contouring, finishing, polishing, and then either do an overglaze or a natural glaze on it, right? So with this, I complete the recall of prosthodontics. Mixed bag of questions. The questions that were straightforward were very straightforward. The questions that were tough were genuinely very, very tough. I am sure all of the other questions would balance out even if you have made any mistake. Now is probably a time where you should, I think, relax. These sessions are there to probably clear up any doubts that you have and guide you towards the correct path, but it should no way lower down your confidence. Mistakes happen here and there. You should acknowledge what efforts you've put in. It's year-round hard work or maybe years of hard work and months of hard work that you've put in. So firstly, you should congratulate yourself for that and take a good night's sleep. Come back tomorrow, watch the different sessions, see what you have done through it. If there are mistakes, mistakes happen with everyone. But despite all of that, I wish the very best for all of you, that you get the rank you desire and you come out with flying colors. This is me, Dr. Ruchi Raj, closing of this Prostho live recall, and a very good night to all of you.